Good afternoon, everyone, and thank you for joining today's Aspire to Knock Out Pneumonia Readmissions webinar series, webinar number 7, in-person workshop preparation. We would like for these meetings to be very interactive, so we're anticipating that you will be highly engaged in today's session. We encourage you to ask questions and share information throughout the webinar today utilizing the chat panel. We will be keeping all lines muted to cut down on feedback, distractions, and echoing. Before I get started, I'd like to go over the logistics for today's session. All lines are currently muted and in listen-only mode. Please chat with your colleagues, hosts, and panelists throughout the webinar today utilizing the chat panel. You can find it by clicking on the chat bubble at the bottom center left of your control panel. Please make sure your to setting is set to all panelists and attendees. The session is being recorded and will be made available on the NCHA website and through email notification shortly after the conclusion of this session. Facilitating for you today is Trish Vandersee, Program Director of Quality and Clinical Performance Improvement of the NC Healthcare Association. And presenting today is Dr. Amy Boutwell, founder of the Collaborative Healthcare Strategies. And at this time, I'd like to turn the presentation over to Dr. Boutwell.
Okay, great. Thank you, Sarah, and thanks everybody for joining today. It's great to be with you. Today, as Sarah mentioned, is webinar 7, hard to believe, of the Knockout Pneumonia Readmission series. And one thing that we've noticed is that we're always getting new people. Oops. Am I sharing? Okay, great. Sarah, you can hear me okay?
Yes, I can, Dr. Boutwell.
Okay, great. Thanks. So one thing that we're noticing and that we know is that new people come onto these webinars all of the time. And so just to remind and refresh everybody, this is month 8 and webinar 7 of the Knockout Pneumonia Readmission series. And the series really is meant to meet you where you are in your readmission reduction work. Obviously, what brings us together is our focus on the very high pneumonia readmission rates and as well as pneumonia, readmission mortality. And so what we're doing here is we are seeking to, sorry, one thing I use slideshow. Let me see if that's right. Okay, great, thanks. What we're seeking to do is to apply best practices and specifically the Aspire method to help you apply the Aspire method to your efforts in reducing pneumonia readmissions, which is our top priority here together, as well as use these principles to help you in your readmission reduction work in general. And so far, what we've been doing is we've gone through a very robust curriculum. You can see starting in March, and here we are in October. So we've gone through the full Aspire guide and related tools. And then last month in September, we talked a lot about taking these concepts into implementation, and we talked about the Aspire Plus implementation model, which I would really encourage you to think about, and it will be a topic of some of our work in the workshop in November. And so what I'd like to do today, now that we've gone through the full curriculum, what I'd like to do today is basically I've prepared a set of slides for you to take back to your team or to use the next time you have a readmission team meeting, or maybe you can do this work right here and now while we're together, and use some of the slides that I've prepared for you to identify what you might want to look into and what you might want to be ready to come to discuss and work on when we get together in a month in November, on November 2nd. And so the November 2nd workshop is really meant to be interactive. It's basically an opportunity to get one-on-one coaching, direct feedback on your questions, your challenges. Obviously, we are eager to hear about the successes that you've had and the lessons that you've learned. And so we're limiting the workshop to 75 spots. And here's basically the registration and attendance information. So we'd love you right now to register if you have not registered. Hopefully you can join us November 2nd. And we're basically going to have a working session where I'm hoping that groups of a couple of you, I mean, if only one person can come from your hospital, totally fine. but it's always nice to have someone from your hospital to talk some change ideas over with, especially when you already have work underway. The hard work about identifying change ideas is what's going to fit, what builds on what we're already doing, what fits with what we already have underway, or who might be a good champion to test these new ideas with. So if you can come as 1, 2, or 3 from each hospital and really consider this day not as an educational conference, that's the big difference. It is a workshop. What I am hoping to do is I want to know about your hospital, your readmission rates, what you have in place for readmission reduction, what you feel like's working, what you feel like should be working but doesn't quite seem to be getting the results you want to get. That's the type of a workshop that we're going to have on November 2nd. So again, register and think about whether or not you'd like to bring a couple other colleagues with you so that you can really use this day almost as a little mini readmission team meeting. Sometimes when I do these workshops, I literally have participants, texting their person in quality or IT or case management to see, can you commit to doing, to creating a flag, or can you help me do some readmission interviews? And so it's really all about taking next steps. So hopefully that paints a picture. I'm really looking forward to it. So as a reminder, the Aspire Guide has been a widely disseminated guide on reducing all-cause readmissions, and it really takes us from where we all started in the field on a focus on Medicare readmissions, and it really kind of takes us into the broader domain of looking at readmissions from a broader lens than just the Medicare lens. And so you can see here in the driver diagram, hopefully you're all well familiar with this and you have it hung up in your readmission team conference room. But the idea around the central concept of the Aspire Guide is that successful teams who are getting their readmission reduction results, so that's on the left-hand side of the screen here, reduce pneumonia readmissions or reduce your readmissions overall, engage in work in 2 co-equally important areas. The first domain of work is that they have a data-informed design. They know who they're targeting, why they're targeting them, the root causes of readmissions for those populations, and they know what resources, assets, teams in the hospital as well as across the continuum are already in place, and use all of that information to articulate what we call the multifaceted portfolio of strategy. And then moving into the deliver buckets is that multifaceted portfolio of strategies that gets results usually, well, in every case that I've studied, usually involves a 3-part portfolio of strategies, which is what do we need to do within our own 4 walls to improve transitional care for all patients across the board. Number 2 is how do we actively collaborate, yes, with post-acute partners, but broader than that with receiving providers and agencies across the continuum, so we have really tight, closed-loop, definitive, collaborative transitions in care. And then number 3 is what services do we deliver for the purposes of reducing readmissions that represent not standard care. That's what I call the enhanced services for the highest risk patients. So this is the Aspire driver diagram, and it really defines the strategy that successful teams use when they achieve their overall readmission reduction, or when, the strategy that successful teams use as they pursue reducing readmissions overall. We then moved last month into the implementation model, and that's content that you cannot find in the Aspire Guide. So, so I would refer you back to the September webinar as we talked about the implementation model. And this is really experience and measures and insights around implementing whatever it is that you decide your patients need in order to reduce readmissions, and doing so and with high reliability. So you've probably all heard that term high reliability before. And a key breakthrough lesson is if we have a really good set of ideas where we want to use teach back and we want to engage the care partner and we want to make appointments before people leave, we want to make post-discharge calls and get home visits done in a timely manner once they do leave, if we only do those things half of the time, I can promise you, you will get zero results. So this is the tough thing about readmission intervention implementation, is that we need to reach high levels of consistent delivery of the intervention until, in order to see those readmission rates fall. But doing something half the time, sometimes when we can, is not going to get results. And that's just from 10 years of experience seeing teams trying to do this. So the objectives for today's webinar are the following. I'd like to bring to you some of the Aspire concepts into your readmission work for your pneumonia patients. And in particular, I've prepped up 4 slides to keep it straightforward and to the point. 4 slides that I would encourage you to fill out in October. Whether or not you come in November, I would encourage you to take these slides, take these tools, and make sure that you feel like you have answers that satisfy yourself, right? The only readmission reduction strategy that matters is the one that's relevant to you and your hospital and that you have confidence in. And that if you understand your data and your root causes, you have a design of interventions that matches and addresses those root causes, and you deliver those interventions with high reliability, then I would predict that you ought to be getting the results that you want to see. So if you don't have these 4 things, then it would be an opportunity for improvement and for consideration. And so as a result of going through these 4 domains today, I hope that as you're listening, again, you're welcome to chat in any questions at any time or any comments, but I hope that you'll identify 3 ways that you feel like you should prepare for the November 2nd workshop, because the November 2nd workshop, think of it as a consultation and as, again, like I said, a readmission committee meeting. This is really time to help tighten up your work because we're all working as hard as we can. And what we really want to do here in the Knockout Pneumonia Readmission series is make sure that you're getting the best advice and able to apply that advice to get better results for your patients, because we know that's what brings us together. We've got to get these pneumonia readmission rates down. So let's think about, I'd like you to think about your current state. And this is where, honestly, I would want you to have a notebook out and a pen and ask yourself these questions, about data, root causes, design, and deliver. So I'm going to walk you through slides on each of these, and you might want to make yourself a note to follow up and work with these slides as a result of having been on this webinar. So number 1, readmission reduction aim statement. A lot of people know that they're working to reduce readmissions. A lot of people will tell me we're working to reduce readmissions for high-risk patients. We want to reduce readmissions this year. So high risk and this year are not specific enough yet to get us a really good aim statement. And so I want to just walk through with you what constitutes a really strong aim statement. And the basic rubric that I always come back to, I learned back at the Institute for Healthcare Improvement, the IHI, and it's what, for whom, by how much, by when. So just rolls right off the tongue. Once you memorize it, it's with you forever. And for those of you in quality, whether it's readmissions or central line infections, what are you trying to do for which patients, by how much, and by when? And these are the elements that I really want all of you to have in your readmission reduction aim statement. So in some cases, it's very, the answer is very straightforward, reduce readmissions. Now, some of you might have a modifier on that. For example, you might say reduce unplanned readmissions or reduce potentially avoidable readmissions. Now, for those of you that have been attending the full webinar series, you will note I have never once used those two terms, unplanned or potentially avoidable. And it's not by mistake. I believe that there is power, important power and information in looking at all of your readmissions and asking the simple question of all of our patients who were discharged, in this case of all of our pneumonia patients who were discharged, how many of those came back within 30 days for any reason? Now, are you going to find a couple patients who came back for a planned procedure, a post-obstructive pneumonia due to a new lung cancer, and that they were scheduled to come back in 14 days for a biopsy? Yes, you will find that. But especially with regard to pneumonia readmissions, there are precious few planned readmissions in this particular topic space. So, and then with regard to the term avoidable, I believe that avoidable or potentially preventable, I more than believe I have seen from my eyes that those terms are subjective and they are in the eyes of the beholder. I was just with a Medicaid ACO in New York State yesterday. And among their Medicaid patients, right, so these are patients obviously with a high prevalence of behavioral health comorbidities as well as a high burden of social needs, they have reduced readmissions by 50%. 50%. And they had me come speak to them because they knew they can do better still. They're not talking planned, unplanned, potentially avoidable, related, unrelated, all of those modifiers. Once you get good at reducing readmissions, every readmission to you will look like it's potentially avoidable. So this is to say, ask yourself, right now, you go to readmission meetings, maybe you're pulling the readmission data, maybe you're the readmission champion who defines what your team is working on and looking at, and ask yourself, do I have a modifier on readmission, or is the answer in the first box, we're working on reducing readmissions? Okay, next, for whom? Well, what brings us together is pneumonia patients, but Trish and Karen and I fully well know that your hospitals have a lot of priorities with regard to reducing readmissions. So maybe your aim statement is to reduce Medicare readmissions. Maybe it's to reduce all-cause pneumonia readmissions. Maybe it's to reduce, Medicare penalty diagnosis readmissions. Maybe it's to reduce hospital-wide readmissions. But this is the most important box in terms of being specific. If your instinct here, as you listen to me speak, is to say, well, for whom the answer is high risk, well, you need to know what is your definition of high risk. And without going too far into it, unless somebody asks me a question, if your definition of high risk is what your computer risk algorithm gives you next to the patient's name, then at minimum, I ask you to please know what that algorithm is. If it's LACE, you can ask me about LACE. If it's modified LACE, there's some other indices. There's some other risk scores. But if you're working to reduce pneumonia readmissions, or we'll just even put it this way, what brings us together for the past year is the fact that North Carolina has super high pneumonia readmission rates. That's what we know. That's what the data says, and that's why we're focusing here. So if you're using an algorithm that does not specifically identify each and every single pneumonia patient, then I would ask you, is that really what you need to be doing? Maybe you say, we're going to reduce, in the for whom, we're going to focus on all pneumonia patients, plus patients with a high risk, ABC risk predictor score. But what I can promise you is you will not be reducing readmissions you will not be reducing pneumonia readmissions unless you focus and identify on your pneumonia patients. Your risk predictor model is not going to consistently give you the patients in your hospital today who have pneumonia. So look into that, think about that. This is where I most often need to dig in with teams and rethink about their targeting strategy. This is your targeting strategy, is this second bucket. I would like it to say all pneumonia patients, or as per the data, all Medicare pneumonia patients. Okay. Now, the third box is by how much. Well, we say a lot of teams are given corporate targets. We'll say, oh, we're supposed to have a readmission rate target of 10% by the end of the year. Or we're supposed to hit 10% quarter in, quarter out. Well, if you think about a target versus what the classic aim statement rubric is, which is here, what, for whom, by how much, by when. We are making improvement, and we need to know by how much are we making improvement. When a team tells me we need to hit a target of 10% readmission rate, all-cause readmission rate per quarter, I cannot make sense of that because I don't know if we're at 10% or 11.2% or if we're at 15%, right? So the by how much, again, I know this seems like a straightforward slide, but you can see how important it is when you actually use the aim statement construct correctly. Is you might tell me your target's 10%, but I don't know how far we have to go because I don't know if you're at 11% trying to go to 10% or if you're at 15% going to 10%. Very different stories. So that's why I wrote here relative to a baseline or some sort of starting point. So in the Knockout Pneumonia series, we want you to aim in general to reduce Medicare pneumonia readmissions by 20%. That would be meaningful. And I've given you some example aim statements down here that would show you some variation. But in general, we're making a reduction of 20% based on where you start. So some of you on November 2nd might quite honestly say, we're starting from here, November 2nd. We've listened to the webinars, but we really haven't put ideas into action specifically. So our start date is November 2nd, if you will, and thus all rates as say it's 8, and you want to improve by 20, that 18% readmission rate, right? So that gets us to the last. By when? Admission coaching, and sometimes I've been getting on phone calls in September and October saying we need to reduce readmissions by 15% by the end of the year. That is a tall order, right? To achieve something in 90 days is a lot different than to have 6 months or a year. And that's the right time frame for a disease or target population specific aim statement. So if your aim statement is to reduce pneumonia readmissions for patients discharged to home by 20%, then I would say in the next year, by next October 1st. If your goal, some of you I know on the line are setting hospital-wide goals beyond pneumonia. If your goal is to reduce hospital-wide readmissions, you need to look at least a 2-year time frame for that. If you're going to reduce all-cause hospital-wide readmissions, that's a 2 to 3 year goal. Target population goal is, depending on how broad it is 6 months to a year. Okay, so that helps you know how often you need to measure your data and how often you need to be pacing your meetings and your PDSA cycles, right? So if you're trying to achieve a pneumonia readmission reduction, well, by the end of the year, starting today, that's 90 days, you'd best be meeting every week, right? And you want to have a weekly dashboard and a weekly implementation dashboard. And you could probably make a push to get something like a 10% reduction if you really drove a process between now and the end of the year. But there's no way a monthly readmission committee meeting and a quarterly meeting with your SNF partners would get that job done. So you can see how the time frame really is important because it conveys where you're starting from, when did you call go, and how long you have, which is important, as I said, for then pacing your work accordingly. Okay, so I hope that, I'm just going to check the chat to see if there are any questions. No questions and no chat. Just double check here. Yep. So work with this and make sure you have an aim statement that is comprehensive and informative. So then number 2 is to understand the root causes of readmissions. So we remember from some great pneumonia readmission reduction work, Novant has been celebrated as having some really great work on reducing pneumonia readmissions for their African American patients. And much of the insight was around identifying the need for more support and more frequent check-ins and interaction, navigation, problem solving over time. You can't get that really from a chart review. You need to get that from the people and their care partners and an understanding of how the care system works in your community. So the readmission interview, you've heard me say this before, but I've kind of summarized exactly what I say. You'll all remember that I am a practicing physician and I readmit people every time I'm at the hospital, promise. And so this is what I say, and it's part of literally my, I don't know, 5 to 10 minute history that I take when I meet people in the emergency room. And just like I look at their vital signs, because I'm me and this is what I work on, I always look to see when was the last time they were in the hospital. And whenever I see that someone has been here recently, within the past 30 days, but recently is good enough, whenever I see that they've been here recently, I include this in my history, right? I say, you know, why are you here? Tell me how you feel, what's been going on. And then I get to this. And I say something almost exactly like this. I see you were recently discharged about however many days ago. We'll say 10, about 10 days ago. I'd like to just take about 2 or 3 minutes to focus on the past 10 days and talk about what happened between the day you were discharged and the point at which you, or maybe it was someone else, decided that you ought to return here to the hospital tonight. Okay, so what have I done in that one paragraph? I've acknowledged that I see that they've been recently discharged. I've bounded the discussion by saying 2 or 3 minutes. Now, I retain the right to go as long as I want, but most people fear doing the readmission interview because they have this idea in their head it's going to take a half hour or even worse, an hour per patient. That couldn't be further from the truth. This is not that kind of a discussion. So I forecast for the patient or the care partner at the bedside that I'd like to just take about 2 or 3 minutes. And that tells them that we're just going to kind of get right to it. What happened, what happened, what happened, what happened? Tell me, and then what? Okay? So I forecast 2 or 3 minutes to bound the time on the discussion. And then I tell them, I just want to talk about what happened between the point at which you left and the point at which you decided to come back. Now that's important for you to appreciate because this is the information that is exactly not in the chart. Even if they had a home health note or even if they had a PCP note, yes, of course you want to read that and use that as information, but that's not the story, right? A PCP visit was 15 minutes within 10 days worth of time. So what we need to know is what happens. Okay, and then as I've come to appreciate as I teach this readmission interview to people across the country, we then need to bring 3 skills to the table. It's very straightforward, and I know you can all do it. It's ask, listen, and observe. And I say that because a lot of work has been going on to take the readmission interview concept and turn it into a checklist, right? Did they do this? Did they get their meds? Check. Did they go to an appointment? Either check or no check. Did they have transportation? Check. Did they have, even food in the fridge? Check or no check. As if the facts are the answer. The facts are not usually the answer. This is what you're looking for. So you ask this 1 paragraph question, and then you listen to how they respond. So first of all, I'm not kidding. Last time I was on call, I had a lady who said, well, my back pain started in 1982. Okay, wow, that's all she needs to say. And I know that this river runs deep, right? So if you ask a patient what happened in the past 10 days and she takes you back to 1982, you know that this person has a lot of anxiety and concern, maybe frustration over time. Maybe she feels like nobody really understands her or gets her. That is a totally different set of understandings about this patient than just, did your back pain flare up again when you were weeding the garden, right? Okay, so another example is whether you have, for example, a care partner, and I'll just say a daughter at the bedside who has her notebook out and says, we were discharged at 2:30, and when we got to the skilled nursing facility at 2:53, my mother had not had her lunch yet, and she was then 30 minutes late for getting her 3 p.m. meds. Okay, so again, paints a very different picture about who's involved with what level of detail. Third example, you ask a patient, I'd like, tell me what happened between the day you were discharged and the point at which you decided to come back. They don't make eye contact. They pull the sheets over their head and they roll over and basically try to get you to go. Very different, right? What's going on with this person? They don't want to talk about it. They're avoiding you, etc. So that's the ask, listen, and observe. Please avoid the temptation to turn the readmission interview into a checklist, because what we need to know is in the discussion, and we need to know, are we dealing with a set of circumstances that unfolded and we can pinpoint exactly what happened because the meds were late and the mom got delirious and I don't have confidence in that skilled nursing facility, so I'm bringing her right back right now, and I'm not going to go back there, right? You've all heard that story. It's universal. Or are we dealing with someone who's really not, who really wants to be left alone, maybe wants to be here in the hospital, maybe feels like he needs some peace and quiet and to get away from something, right? Who's the person who pulls the covers over his head and rolls away. So these are very different things. And I emphasize this because I've been teaching the readmission interview now for the better part of 10 years. And often when I ask people to go out and interview 10 people, they'll say, well, they'll say a couple things, but one of the things they say is I tried to talk to a couple patients, and one person had dementia, and one person refused to talk to me, and so I was only able to talk to one other person. Well, this is where I'll bring your attention to the asterisk on this slide, which is in my job as a physician and our job as a care team, when we're trying to collect information about somebody that we need to take care of, if they can't speak for themselves, or if we can't get adequate information, then we need to reach out to what everybody calls collateral information, right? To other to other people involved in the patient's life and to other providers involved in their care. And so this is where you is not a literal you. You is the patient, and then as per the way you've already been trained, we need to then reach out, if there's a daughter there, obviously we want the daughter. If there was a doctor who sent the patient in from dialysis, from the SNF, from PCP's office, if there was a home health nurse who was in the home right before the decision was made to send the patient into the emergency room, then we need to talk to that home health nurse. So you is the broad you, and it is inclusive of taking a really good history about what's going on. So that's basically the readmission interview. Now, what I'd like you to do is then interview in the month of October, interview 8 people who have been readmitted. I don't even care if they're a pneumonia readmission. What I can promise you is if you asked your, whoever, your case manager, maybe your director of case manager who gets daily census lists, I'll bet he or she has a daily readmission report or could add to the daily census list. You can usually add really easily the last day of discharge or number of days since discharge. So just create this is a very simple, straightforward process. Who in our hospital today is a 30-day readmission? And for whatever size of hospital, you would at least have one. And if you're a large hospital, you probably have 10 to 20 if you're a large academic medical center. So you can do 8 readmission interviews between now and November 2nd. I know you can. If you just develop a day-to-day process of saying, who here is a 30-day readmission, and then you engage someone on their care team, you or someone on the care team asks this one paragraph question, ask, listen, observe, and just start to collect the stories. 56-year-old lady hospitalized with pneumonia was discharged home, readmitted 2 days later, versus an 82-year-old gentleman hospitalized with pneumonia, discharged to SNF, readmitted 5 days later. These are going to be different stories, and what you want to do is get the story, and then as you learn from 8 or so stories, you're going to start to see some themes bubble up. And with regard to pneumonia readmissions, I have seen these bubble up as kind of pneumonia specific. So the development of diarrhea, and gosh, all of our patients from the community are being sent in for the emergence of diarrhea within a couple days of discharge home. Guess what we just did? We just changed them from IV to PO antibiotics. For some reason, there is a practice habit. Lots of people are coming in, rule out C. diff. That's from the SNF. It's also from home with home care. And so watch for that. Are people just getting kind of bumped right back to, quote, rule out C. diff, which PS you can do as an outpatient, and PS, not all diarrhea associated with antibiotics is C. diff, right? It's an expected side effect of regular antibiotic use. Number 2, persistent cough, right? Any of us who've had pneumonia, myself included, know that you cough for like 3 weeks after, especially if it was an atypical pneumonia. And so people can have a persistent cough, and what they have is the equivalent of a nurse triage question. But if they don't know who to call with that question, most likely their discharge paperwork says if you have fever, cough, abdominal pain, chest pain, call 911 and come back to the emergency room. And so if they don't have specific instruction to call your PCP office, call the nurse triage line, call the urgent care center, call the home health nurse, whomever they're supposed to call, then they might be bringing themselves back to the emergency room with what is the equivalent of an outpatient question. Then we move into another one that's common with our elders and pneumonia who go to skilled nursing facilities would be delirium, altered mental status, confusion. And how do we want our colleagues in the skilled nursing facility to manage a alteration in mental status short of reflexively sending them back to the emergency room? So that gets into some best practices that you can think about. We can talk about at the meeting. And then I'll tell you what, I've been watching for this ever since I started working with you guys on pneumonia readmissions. I cannot tell you how many pneumonia readmissions come down to, quote, bad labs. Have you ever seen that on the ED tracker board? What's Mrs. Jones here for? Quote, bad labs. Well, that's what we do at my hospital, and it's starting to become almost funny to me, in the sense that creatinine bump when you're taking antibiotics, or definitely a big one is the INR goes off in the setting of antibiotic use, and so these things, again, you want to identify these things, because is this an indication for acute medical care, or is it an indication for medical care? And there's a difference. When we're trying to reduce readmissions, we need to really help clarify what is the need to send somebody to the emergency room. Can we evaluate and discharge in the case of maybe a high INR that just needs an evaluation and some vitamin K, or does that person really truly need to come back in for a readmission for the next 3 days? And so these are just some examples of root causes that, as you can see, they're not non-compliance. They are what was ultimately the inciting factor. Somebody might not take their antibiotics to completion, and so they might follow up. They might continue to have a cough and need to come back because they're sick, right? But what is the root cause, the inciting event? Nobody really comes back to the emergency room calling themselves non-compliant. So don't you use that term when you're looking for root causes. Try to get all the way through to what was the reason why they came back, what was at the root cause. So please do this exercise over the next month. I think you'll find great value in it. And then next, when was the last time you just really listed out the interventions that you feel like you're doing, or that you've tried to put in place, that are dedicated to reducing readmissions, and even better for our purposes, pneumonia readmissions? And think about, this is just illustrative. This is not to tell you to do any or all of these things in particular. These are just ideas. What I'd like you to do is fill this out for yourself. What are you doing for the patient while they're here? Now, I do want it to start with, how do you identify the pneumonia patient? And the next step is, once you identify a pneumonia patient, how do you connect the dots between this is a pneumonia patient and thus this is a patient who's high risk of readmission? I'm emphasizing this because, again, the readmission flags and scores in the electronic medical record are not actually helping you with this step of the process. We need to know at the bedside this patient has pneumonia. That's a clinical diagnosis, right? The doctor says it on admission, or they develop it or are diagnosed soon after admission. So the patient has pneumonia, and on the nursing units, we want a process to say all of our pneumonia patients are considered high risk of readmission. That means we're going to do any of the following things you see in this box, and whatever it is that you're doing. Once you identify a pneumonia patient and that all pneumonia patients are high risk of readmission, we need to assess their whole person post-hospital needs, not just for medical care, but for social behavioral care. We need to identify a care partner, and if they don't have one, figure out who is going to be that helper for them. We need to give the patient and the care partner daily updates on the progress and what we're looking for. We're looking for you to not have a fever for 24 hours. We're looking for your oxygen to get better. We're looking for you for your white blood cell count to come down so that we know the antibiotics are the right ones. Whatever it is, you got to update your patients on a daily basis at that level. Many pneumonia readmission stories involve elders. And, you'll remember, and you all know, that pneumonia is a leading cause of death, and we want to help our patients survive pneumonia, unless, of course, the time has come for a goals of care conversation. in which case we should be doing that as appropriate. Using teaching with TeachBack to make sure people understand their medications and how to take them, and including anticipatory guidance. I like to remind people, you know, pneumonia is a pretty big deal, and you might not feel well for about a week. You might cough for a couple weeks after this. So give them a little anticipatory guidance, and then let the PCP know your patient's been here with pneumonia. This is a diagnosis that is high risk of readmission. We want to make sure you're aware of this. Contact us with any questions. Now, I won't go through each of these change ideas, but this is the thinking that I encourage you to do with your team over October, to ask yourself, what are we doing during the hospitalization? What do we do at the point of transition? So I define that as the 48 hours before to the 48 hours after the discharge. And you can see I've got some change ideas in there. And then what do we do for patients once they, you know, after the hospitalization? So this would be 48 hours, you know, basically after the post-discharge call through the rest of the 30 days. And so you might have some blank spots, and that's fine. That would be cause for discussion when we're together at the working session. So try to fill this out, and you'll notice that I have, it's really all about what are we doing on a patient-facing level. So I hope you all know me well enough to know I want you to have a readmission team. I want your readmission teams to be looking at data. I want you to be understanding root causes. I want you to have partners with your care, you know, across the continuum. Those I would call structural, right? Data, root cause analysis, team, cross-continuum team, etc. This is really patient-facing. As I say to some of the teams that I work with, what would your patient with pneumonia experience that, for example, your patient with cellulitis who's not high risk of readmission would not necessarily experience? And so take it away from what is standard operating procedure to what is really what the title of this slide. What are our interventions at a patient-facing level? What are we proactively doing in order to mitigate or address those readmission risks? Next is moving into design. And so what I'd like you to do is make sure you know your data, even at the most basic level I have here in this chart, and I'll just go over it here really quick with you. Based on your data, your pneumonia readmission patterns, and then I want you to think all here on the slide, who's at risk based on your data? What are you currently doing during the hospitalization, at the time of transition, and after the hospitalization? What have you learned there in the circles about root causes of readmissions? And then ask yourself and your team the question, are you targeting your interventions to the right group of patients? And do your interventions actually address the root causes of readmissions? Or are our interventions kind of the standard medical ABCs that have not yet crossed over to being well designed to address root causes? So in this example, and I'd like you all to have a table just like this when you come in November, simple. How many pneumonia discharges did you have? I don't care if it's in the last month or in the last year, whatever's easier for you. How many pneumonia discharges? In this case, this is the past year for a small hospital, and they had 1,000 pneumonia discharges. Okay. How many readmissions occurred after those 1,000 discharges? Answer, 200 for a 20% pneumonia, all-cause pneumonia readmission rate. They had 50% of their pneumonia discharges went home. That's 500. Of the pneumonia patients who went home, 80 were readmitted for a 16% readmission rate. A quarter of their patients went to home with home care, and a quarter went to a skilled nursing facility. And patients in those discharge disposed each had 60 readmissions following those 250 discharges for a 24% readmission rate. Now, I meet a lot of teams that are focused on the hospital to home transition. And look, there's a lot of people, right? There's 500 discharges to home. But it's not driving the readmission rate. Can you see that mathematically? It's your discharges to post-acute care, whether that's home with home care or to skilled nursing facility, those patients have higher readmission rates. And so something that can be surprising and informative is to say, wow, we have a hospital-to-home strategy for pneumonia patients, and it involves, phone call and appointment and transportation and meds to bed or something good like that. And that's great. I wouldn't say stop. But what I would say is, and if this is your data, so what are you doing to address that 24% readmission rate for your patients who go to post-acute care? And that's your next opportunity for improvement. So then the final worksheet slide, if you will, is about delivering and implementation. So are you implementing whatever it is you want to do? It might be teach back, it might be meds to bed, it might be a 48-hour phone call, it might be a home visit or a 30-day transitional care program. Whatever it is, are you delivering the services you want to deliver to the patients that you've already decided to target on a consistent basis? So, for example, we've got time between now and the meeting for you to track this on a week-by-week basis. And the good news is I know from the North Carolina hospital-specific pneumonia readmission data that any hospital in North Carolina has, on average, 1 to 8 pneumonia discharges per day. So it's not hard to track something on a weekly basis when you're talking about, a handful of pneumonia discharges on a daily basis. So in this hospital, this is we'll call it a regular sized community hospital. They've got in between 1 and 2 pneumonia discharges per day on a 7-day week basis. And so we'll say here in the first week of October, they had 10 pneumonia discharges, okay? And 5 of them were discharged home, and their intervention is a pneumonia discharge to home intervention. So 5 of their pneumonia patients were discharged to home. That's 50% of all pneumonia patients. So right off the bat, wow, we're actually ignoring half of our pneumonia patients, and that's food for thought per the prior slide. But moving forward, we say, okay, so we had 5 discharges to home. And what we wanted to do, what our process is we do bedside delivery because we know they're high risk and they need those antibiotics in hand. So we do bedside delivery, we make an appointment before they leave for a 5-day follow-up, and we do a 48-hour follow-up phone call. So I want you to just simply count how many of those patients got any of those things. So 3 got meds to bed, 3 got appointment made, and 2 got a completed, not attempted, a completed follow-up phone call at 48 hours. But how many got all 3 of those interventions? That's a different story. 1, right? So this is so valuable to you because you're working hard and you actually have really good interventions. This is a very fine project. But if only 1 out of your 5 pneumonia discharges to home are getting the package of services, then clearly we've got a beautiful opportunity to think about, what are the gaps? Why don't patients get 1, 2, or all 3 services? How can we tighten that up? How can we make it more reliable, one-step shopping? Can we create an order set? Can we create a dedicated team? What can we do to increase the reliability of our package of services? Because if a patient gets 1 of these things, I'll promise you that it's not going to reduce a readmission. But if they get all 3 of these things, hey, I think you've got a project there. And I think that you could get some results. But you can't get results unless you're delivering the whole package. So similarly, for those of you who are focused on patients discharged to SNF, which I hope some of you are, let's just say the same hospital, exact same hospital, they're already smart to their data, right? You already know this, and you know that 5 of your pneumonia patients go home without home care, and that 3 of, and a quarter of them or so go to skilled nursing facility. And what you're doing for the skilled nursing facility is you're doing a warm nurse-to-nurse hand. So in this week, we had our 10 pneumonia patients, just like above, and we had 3 discharges to SNF. All 3 out of 3 got the warm nurse-to-nurse handoff, but we had the little bit of a fall off on only 1 out of 3 completed the circle back call. We have it in our head. We think we're doing it, but the data shows we're not actually doing it as consistently as we hoped we were. So I encourage you to really work with this type of weekly implementation dashboard, whatever is relevant to you, and bring it for discussion when we get together next week. So in the spirit of accelerating your progress, today I went over these 4 slides. It's a lot of information, but it's you know, if there are, I really tried to basically break it down. If there are only four things to do: data, root causes, interventions, implementation dashboard. I'd like to remind you, though, of the Aspire guide, and that there are 13 tools, some of which I don't want to totally forget about, like the driver diagram and the community inventory. Also, the tool 8, the conditions of participation handout. So there are tools. These are all downloadable from the ARC website. We've discussed them in webinars past, but I just wanted to remind you that as you prepare and think about coming to November, or if you're not coming to November, making progress in your work moving forward, remember to take a look at some of these tools. In addition, you may not have taken the time to read the Aspire guide. And people who have read the Aspire guide tell me that it kind of, it's a book, and it kind of ties it all together. And so if you've attended some of these webinars, but not all of them, or if you've attended the webinars, but you still don't feel like this is making a coherent sense to you, then I would invite you to read the Aspire guide, again, freely downloadable on the ARC website. There's also, in particular, I'll bring your attention to a 10-part whiteboard video series that I did for the American Hospital Association. You've listened to now 7 hour-long webinars. And what we did with the 10-part whiteboard series is I broke down some of these key concepts, like the readmission interview, or know your data, or partner across the continuum, into about 8-minute video clips. And you can use those video clips in your team meetings if you find them helpful. So you might find them helpful for yourself, but also they're meant to kind of watch and then incorporate maybe into readmission team meetings. So just more resources for you to consider as we get ready to have a great day together. So I'd like you to just reflect for a moment, maybe make yourself some quick notes. What are 3 things that you can do here in October that would make your participation in the November 2nd working session really worth your time and worth coming? And so as you think about that, you might just use this as a checklist. These are ideas. They're recommended, not at all required. We want all of you to come and participate and learn and think about your readmission work. You don't have to have any of this done, although hopefully you can see the more you do and the more you come, the more helpful I can be and the group can be in helping you work around and innovate for better results. So you can, I won't read this checklist out to you, but this is a checklist that I would recommend you go through some or all of these in this month, and bring what you find, bring what you learn, or if you learn something that doesn't make a lot of sense to you, bring it to the meeting, and this will be the food for a great conversation and a really exciting workshop when we get together. I'm really looking forward to seeing you all in November. There's nothing like an in-person meeting to kind of bring life to this work. I know you're working hard every day to reduce readmissions, including for your pneumonia patients, and I really want to help see each and every one of your hospitals and the entire state of North Carolina hit these important readmission goals for your pneumonia patients, because it really is important, and I know we really can do better when we put our heads together. So with that, I will thank you for your time today, and I'll just remind you, any questions at all, contact Karen or really Trish here, who's the program director, and please do register for the meeting, and we will look forward to seeing you then. So thanks a lot. Sarah, I'll turn it to you to close us out.
Thank you so much, Dr. Boutwell, and thank you everyone for joining us today. We will be sending out some more additional reminders to register for the November 2nd session. And we will also send you a link to evaluation for today's webinar. Please fill that out, as we do take the feedback into consideration for future webinars. We will be having one more webinar after our November 2nd session in December, and that will close us out for the Aspire to Reduce Readmissions sessions. Please join us for that, and we look forward to hearing from all of you at the November 2nd session and the December webinar. So thank you again for joining us. That concludes today's session, and we will, you may now disconnect. Thank you.